I'm going to change my screen a little bit. If I do this.
All right. If everybody's ready, I'll give you guys a second.
There we go. Okay, we have it on full screen here.
All right, so we'll get started. So, just to start, we have an 82-year-old female. During yearly checkup, was found to have abnormal macula, medical history, just hypercholesterolemia. Whoops, I can't see this. Melanoma on the back, surgical history of a hysterectomy, and then here you see your systemic meds, just some atorvastatin, bumetanide, amlodipine, alprazolam, omeprazole, vitamin D and claritin, and raloxifene. And then visual acuity, pretty good with correction, 20/25 OU, and then pressure was 17/15. So I don't know who, did you pick somebody to go ahead?
Yeah.
Yeah. Okay, so we're looking at color fundus photos of the right and the left eye. Starting with the right eye. Kind of hard to tell if the media is a little bit hazy, but the nerve looks pink and sharp. Vessels maybe a little bit attenuated. There's some kind of hypopigmentation in the temporal superior macula, and then also superiorly along the arcade. Let's see. And the left eye, kind of similar, similar to the right eye. The nerve is pink and sharp, but there's kind of these more areas of these like white hypopigmentary changes in the macula closer to the fovea on this eye, and then also superior along the arcade, and then kind of these lighter areas of hypopigmentation along the superior arcade as well.
Great. Yeah, so we have one more, little bit more detail.
Some multicolored picture.
Okay.
Funny picture.
So do you describe these the same way?
Like, you can just use colors.
Okay.
You know, you could use reflective, but I would just say colors. It looks a little green.
Okay.
Or the green,
yeah,
the green. David talking about this one. The green is closer to you. The red's a little farther back.
Okay. So kind of centrally around the fovea, there's just like large green colored pigmentation. And then a little bit worse in the left eye. I would say then you see those like white kind of, I wouldn't say fluorescent, but like white pigmentary areas as well.
And those white areas are pretty sharp. They're pretty, I don't know, well defined, I guess, sharp.
Yeah.
Yeah.
Okay. So this is a fundus autofluorescence, and looking at the right eye, kind of looks like a speckled pattern. Like I'm seeing hyper and hypo autofluorescence, both superiorly and towards the arcade, and then also superior to the fovea, kind of right around the vessels. And then in the left eye, you see those areas that looked white in the fundus photo are hypo autofluorescence here, and then you also see hyper autofluorescence kind of between the nerve and the fovea.
Does anybody other than Bryan know what those little speckled, the peripheral speckled things are? What's that?
Like
Yeah.
style changes, like reticular.
Yeah, reticular. Those are classic reticular pseudodrusen. So the speckled patterns is where they are, what they look like, their size, their clustering. Those are like super duper textbook reticular pseudodrusen.
Okay.
Good. Now you got your OCTs.
There's a lot of images, right? Aren't there a lot on this, Bryan?
Yeah, but we'll scroll through a few of them. These are the main ones. So go ahead.
Okay. So looking at an OCT here, I'm seeing like kind of PEDs, what it looks like, throughout the fovea and parafoveal. Looks serous. I'm not
Yeah.
really much intrusion there. I don't see any like intraretinal fluid.
Good. And then here's your left eye.
Looking at the left eye, so kind of starting temporally, we see similar like PEDs there. But then coming more towards the fovea, there's like almost looks like calcific changes in the outer retina. And
You're generally better off staying out with hyper-reflective, shadowing,
yeah,
right? Jumping to calcium is a little tricky.
okay.
You get in trouble for that.
So there's like discrete areas of hyperreflectivity, and then there's also shadowing behind that, behind those areas. And then questionable like hyporeflectivity is even more nasal to that, towards the nerves versus fluid.
An earlier ischemia too.
And
So,
here's your face.
okay, so now we're looking at a FA.
Good.
Seeing kind of similar findings here, both looking at the right eye, there's hyperfluorescence temporally near temporal macula, and then kind of that similar like spotted pattern of hyper and hypo fluorescence with maybe some hypofluorescence in the like near the fovea.
Now, you've seen the OCT already, but if you didn't have the OCT, just a fluorescein, would you say those are the borders of the hyperfluorescent lesions in the center of the macula pretty stable? Because those are early and late pictures. Do they
Yeah,
change?
the time that you're at is like about 2.5 minutes and then like 4.5 minutes.
Okay, they look pretty stable to me.
Yeah, so your edges are stable, so that is
Mhm.
there or is there not leakage?
So I say no leakage.
So if the edges are stable, we say no leakage.
And this is
So,
about the same times as well, like about 2 minutes and 45 seconds, and then like 4:30 as well, or something.
You know, I saw this lady yesterday.
uh-huh.
She's doing a, tell you later.
So throughout the macula, similar findings of like these kind of just more discrete areas of hyperfluorescence. They also look stable. I don't see leakage there. There's areas, kind of spotted areas of hypofluorescence superiorly and in the central macula. And then looking at the nerve, I would say there is this area of hyperfluorescence around the nerve, but that may be a little bit of leakage there.
Yeah, good, good. So when you're looking at the area just temporal nerve, if you look on the left and the right, it changes some, right?
Mhm.
And the border smudges. Like if you look at the left, you can see like a discrete area, like little dark spots between it. And then when you get to the right, it's just a smudge.
Mhm.
So that's, and again, you have the OCT showing fluid, but that shows if you didn't have it.
Good. And then our last couple photos. Here you go. You got your ICGA.
Okay,
And
so
the time you're at, by the way, your time is at 1 minute on the left and then about 15 minutes on the right.
okay, looking at the ICG, seeing this like central, is this also hyperfluorescence?
hyperfluorescence.
Okay, like central, discrete area with irregular margins of, hyperfluorescence with kind of speckled, very sharp pinpoint of hyperfluorescence within that. And then kind of a central area of hypofluorescence within that as well. It doesn't really like look like it changes much either.
No, it doesn't. In ICG is good for that. It doesn't really leak much. It's it's more protein bound. And the, when we see something in the macula that's small, like we call it drusen, but something big, we typically call it, you know, the word we use for bigger. Sponge. It's trying to get something out of it. It's like something you put on your wall if you win an award. It's
Like a plaque?
Yeah, plaque.
Okay.
We tend to use something on your teeth. We use the word plaque, like plaque, like if you had, you know, if you had AMD or anything, this is sort of like, for ICG speak, this is considered like a plaque.
Okay. So looking at ICG of the left eye here, similar findings, you could say like a large hyperfluorescent plaque, pretty much covers the entire central macula. And then with hypofluorescent, kind of discrete, speckled pattern superiorly and inferiorly around that.
And then what about on the nerve, the second
And then-
lesion? So there's almost like there's two things going on.
Yeah, on the nerve, there's that area of hyperfluorescence, which it looks like it changes, so it leaks a little bit.
Mhm.
Good. And then just so you know, we'll go through these really quick. These are about 13 follow-ups. And just of note, Dr. Cohen did not treat either eye. So I didn't take much from this. We can go back to this a little bit later, but I don't want to give anything away. So just going through it, you just see thickness maps just over these follow-up visits, and there was no treatment that was done. Is there anything else you wanted to add, Dr. Cohen? I didn't know what to.
No,
make
that's good. That's good. Perfect.
Okay. So just as a case summary, I'll go through this with you guys real quick. You did a really good job, by the way. This is kind of a tricky one. But color fundus photos, on the right eye, you had a little gray, green macular lesion. And then you also had some pigment or lipofuscin accumulation in the central mac. And then on that left eye, you had that fluffy white hyperreflective exudative material. On autofluorescence, there's scattered punctate hyperautofluorescence with areas of hypoautofluorescence. And then on the left eye, there was a couple areas of blocking that corresponded to that fluffy exudative material. OCT MAC, you had multiple parafoveal hyporeflective core drusen or PEDs with thin double layer sign. I can go back to those photos just to kind of point out what I'm talking about. And then on the left eye, more temporal, you had a single, more solid drusenoid PED, and then a little bit of intraretinal fluid that you pointed out next to the nerve. And then some intraretinal hyperreflective foci with hypotransmission defect or like pigment migration. And then FA, mostly staining without leakage. There was maybe a little bit of leakage on the left. Whoops, sorry. And then ICGA, as Dr. Cohen mentioned, hyperfluorescent plaques with late staining. And then we really only had early and late, but then he did include one photo that I didn't put in that was like kind of more mid-phase. It didn't really change a whole lot, but it was like a hot spot. You can kind of see that to the left there, temporal to the disc in the left eye. I think that covered most of it. Let me just go back real quick so you can see so if you look here, that's kind of what I was saying. So left eye, you see that solid PED, drusenoid PED far temporally. And then you see these hypo-reflective cores with thin double layer signs. And then you have that intraretinal hyperreflective foci, and then the hypertransmission.
Use your pointer, we'll see it.
Oh, can you see my pointer?
Yeah, we can see yours.
Oh, okay, so yeah, then you have this intraretinal hyperreflective foci, and then you have that hypotransmission defect, and then these little cystic areas, intraretinal, that we suppose could be some fluid. And I think that was mostly it.
And for the double layer, the other eye will be better because it's less pathology. And that's considered a double layer sign.
Yeah, double layer sign.
Irregular. It's not a perfect double layer. The double layers are generally a little more irregular. That's a little more irregular than you'd like, but it's still a double layer sign.
Yeah, and as I was reading about it, I mean, I don't want to get too into it, but yeah, there's obviously distinctions too in the literature about, thick or thin double layer signs, just whether there's two or one or two bands between the RP and Brooks. But anyway, we'll go on.
So you gotta get it different.
Was there anything else you would add to the summary of findings, Dr. Cohen?
No, that's good. That's perfect. Very nice.
Okay. All right. So for differential, you want to give me some?
Yeah, I feel like double layer sign is a buzzword and I'm blanking on that.
That's a new one. You could skip that and do anything else.
I feel like a differential would be like age-related macular degeneration, possibly like chorioretinal neovascularization versus like an inherited macular dystrophy.
Great. Yeah, that's really good.
Yeah.
Yeah, kind of covers it.
So yeah, age-related macular degeneration, myopic macular degeneration, non-exudative macular neovascularization. You have central serous, vascular occlusion. I just gave a whole long list of these. But this was a case of non-exudative macular neovascularization. So just to kind of review, macular neovascularization is kind of the new term used instead of choroidal neovascular membrane to include all neovascularization types in the macular region, with one that's sub-RPE. Type 2, you have subretinal, and then type 3 originating from the retinal circulation. And so in this patient, evidence of macular neovascularization, it would be best seen on OCTA. We didn't have any OCTA here in this case, but if you don't have OCTA, you can see some of those characteristic findings I described on ICGA as a hot spot, mid-face hot spot or plaque, late phase plaque. You won't have leakage on FA, and you shouldn't really have macular fluid on structural OCT. And I'll get back to this, but though non-exudative macular neovascularization can be a precursor to the formation of exudative neovascular AMD, there's evidence that suggests it has a protective effect on slowing progression of GA. And so I'll come back to that in a little bit. So just
the one eye was the left eye was exudative.
yeah,
So
sorry. So by the way,
yeah.
that left eye was exudative. It was asymptomatic wet AMD that Dr. Cohen did not treat, but then you saw some of those other characteristic findings on the right eye that had a little less pathology going on.
And I have to say, when I've come around some, so I used to not treat asymptomatic wet exudative macular degeneration just because none of the studies support it, because nobody was really enrolled in any studies with asymptomatic disease. I've had a couple people do poorly, so actually now I'm a little more likely to pull the trigger on. I still give asymptomatic patients a little bit of time maybe before I treat them, trying to elicit symptoms, but most 99% of people treat exudative macular degeneration, whether it's symptomatic or not.
All right, thank you. And so this is just kind of reviewing some of these definitions that I found in a couple papers regarding this topic. And, what I'm kind of focusing on is this case of non-exudative neovascular AMD or macular neovascularization. And that can either be treatment naive or the lesion that had exudation and is now fluid-free after anti-VEGF therapy. So as we know, pathophysiology of choroidal neovascularization or macular neovascularization refers to angiogenesis within the macula. It arises generally from the choriocapillaris, which results from several chorioretinal diseases. VEGF is produced as a result of ischemia and inflammation, breaking down blood-retinal barrier and stimulating vascular endothelial cells to proliferate and migrate. Growth of these compensatory neovascular membranes and their propensity to cause exudation can lead to profound central vision loss. But in the non-exudative forms, these vessels do not leak, but they can still cause visual disturbance by disrupting the macular structure. So etiology of this, kind of what I got was because non-exudative macular neovascularization is most commonly associated with macular degeneration. The risk factors are people with age greater than 60, Caucasian, family history of AMD, smoking, and then other causes can be anything else like high myopia, ocular trauma, inflammatory diseases, or vascular occlusions. And the prevalence of non-exudative macular neovascularization in fellow eyes of patients with neovascular AMD and exudation is between 5 and 25% is what I found. And then within the first 2 years after baseline detection, approximately 25% of these eyes with non-exudative will go on to demonstrate exudation. And prospective trials have noted similar incidence of fellow eye conversion from non-neovascular to neovascular disease. And so this may indicate that many of these fellow eyes had non-exudative macular neovascularization at baseline. So that just kind of emphasizes the importance of, you know, being more vigilant about this. And so OCTA should be, you know, utilized in future prospective studies. And the signs, you know, kind of like I said, you can get intraretinal thickening, gray-green macular lesion, RPE changes, atrophy, pigment clumping. Just really you can have these shallow, irregular retinal pigment epithelial elevation, the double layer sign, subretinal drusenoid deposits, RPE atrophy, and pigment migration.
One sign we used to look for a long time ago is if you, and which just this patient had, is if you look at a macula and there's a bunch of drusen and then there's an area without them in the middle, that often means there's something going on there, because that's where the either a PED or a macular neovascularization is, because they don't form in that area, or they're obscures them.
Ah, interesting. And then because macular neovascularization itself is typically asymptomatic and the patients have good visual acuity, it's just they can have varying level of symptoms, including, you know, blurred vision, reduced central vision, metamorphopsia, just anything that you'd expect to see in macular degeneration. So for diagnosis and imaging, it's mostly based off of ophthalmic examination and diagnostics. OCT, you have that intraretinal hyperreflective foci with hypotransmission or shadowing. You have those hyporeflective core drusen, and then thin or thick double layer sign. And the specificity and sensitivity for this can be as high as 88% is what I saw in some of the literature. There's not a lot of that I could find on this. So, but anyway, go ahead.
On the double layer sign, or?
Yeah, just on like a consensus on that exactly.
Yeah, it's kind of a newer thing. I think people are still working on it.
Yeah. And then FA, you'd expect to be typically negative for leakage. ICGA, like I said, those hot spots or those hyperfluorescent plaques. ICGA is useful in detecting chorioretinal neovascularization, obviously not visible on FA. And then OCTA, neovascular complexes can be directly visualized. And then early vascular networks or new blood vessels beneath the retina or level the RPE, indicating presence of macular neovascularization, and no significant leakage or abnormal flow as the vessels have not yet broken through the retina to leak fluid.
I get ICGs on my new wet AMD patients on all of them, and I'm looking for polypoidal, and I'm looking for this in the fellow eye. I think I might be one of my only partners that does that, but I think ICG on a new wet AMD patient is helpful.
Yeah, and so for this non-exudative macular neovascularization, multiple studies that I found showed that this can sustain hypoxic or micronutrient insufficient outer retinal cells as like a compensatory mechanism. And so there's evidence that this neovascularization can slow down growth of adjacent GA. As long as the exudation does not occur, it appears that it's not responsible for a great deterioration of visual function. And so, you know, that kind of is the reason why many will argue that they should not be treated until the symptomatic exudation develops. But it is important to note that there hasn't been randomized clinical trials to support, you know, that recommendation per se. Lesions can persist for years without affecting vision. They can provide, like I said, nutritional support to the overlying RPE and photoreceptors. And there is evidence that it can be protective. And so current understanding, recent OCTA, I thought this was kind of interesting that in recent OCTA, recent OCTA studies showed that these large macular neovascular complexes, they don't regress with anti-VEGF therapy, suggesting that they might be mature and less responsive to injections. And so this emerging insight would be that complete suppression after controlling the exudation may be more harmful than good. And there might be a shift in kind of the way we treat in trying to promote maturation and stabilization of the neovascular tissues. And so some of the papers suggest some of these future treatment targets, which could be pathways of angiopoietin, tumor growth factor, beta, platelet-derived growth factors, sphingosine, 1-phosphate, and those could help create non-leaky, non-inflammatory, and functional vessels, leading to long-term better outcomes.
That's pretty, I haven't heard that. That's cool. That's a very clever idea. It's interesting.
So this is just kind of a characteristic picture. Really, I didn't find a ton of great pictures online, and so these are pictures just that Dr. Cohen provided. So this was of our case. Obviously, this is that left eye that had a little bit of exudation, but you see the plaque there on the right.
And it went away. That left eye got better. So that, do you remember how old she was? I forgot how old she was.
82 years old.
Too, because that was 8 years ago. So she's 90 now. And I just saw her and her vision's great. You know, and she has these subfoveal things. And do you remember there was the old papers, like pathology papers, either from Dick Green or remember Foose, the guy, there's a guy, some of these old ophthalmic pathologists, and they found a lot of neovascular membranes on autopsy.
Oh, yeah, it's much more common than is detected out of Australia. It was
clinically. So there was,
Shirley Starks.
yeah, I tried to find those lately. I can't. I look for them every once in a while when this comes up.
Yeah, but she was famous. That was her claim to fame. That we weren't detecting many of the membranes.
Right, and I think part of that, now that we understand this better, is that a lot of those membranes probably are helpful. You know, they probably were physiologic, the people helping the people out.
Well, they were the reason. They might have been the reason many lasers failed.
Oh, and the second thing about this, which I think is interesting, is you said 20, I think it's true. I think 20-25% of people with wet AMD have a neovascular membrane, the other eye that's not exudative. What happens, and I'd love to eventually generate a paper on this because I'm trying to track my cases, is that person might get cataract surgery, get some macular edema, or maybe a little uveitis or something, or macular pucker, something makes the retina swell. And then they have this macular neovascularization there, and then they end up getting on anti-VEGFs instead of more appropriate therapy, which would be steroids. And I think there's a fair number of people out there who are being treated for exudative macular neovascularization when they really have non-exudative macular neovascularization, a second disease that would be more appropriately treated else a different way.
Yeah, I looked up Shirley Starks.
Or papers?
Yeah, she's from Australia.
Okay.